Hi, welcome to Your Health Matters with Dr. Benjamin Bryant, Chief of Staff and Chief General Surgeon here at Conneaut Medical Center. Doc, how you doing today?
Well, I haven't melted yet. Boy, it's getting hot out there.
It is. It has been so hot the last couple of days, but as I've mentioned before, you and I went through the winter where we had to fight the snow and the ice and all that sort of stuff. So I kind of welcome this.
It does make me think back to when I walked out to come to the office one day and it was 15 below with
Right.
the wind chill.
Right.
And it was just frozen. So this is not all that.
We'll take it, right?
We will take it.
I see you have a guest with you today.
Well, we're very, very pleased that Dr. Brenda Beck would come and spend some time with us today and talk to our community. Dr. Beck is an anesthesiologist.
Yes.
And she specializes in pain management out here at our institution.
I do.
And so we're going to go into that today. Generally, it's anesthesiologists who do this. Is that correct?
Correct.
Okay. So where did you do your training in anesthesiology?
I did it here at UH downtown.
Oh, you
Main
did?
campus, yes.
Oh, okay. Okay, well, homegrown is kind of the best. Okay, and so you just decided to stay in this area?
Right, well, so I met my husband and I moved up here.
Uh-huh.
And I guess the rest is history.
I guess the rest is history. Okay, all right, very good. And when people think of anesthesiologists, a lot of times what they're thinking about is somebody who, sort of puts you to sleep for an operation.
Mhm.
But obviously that's not all that anesthesiologists do.
No, you can specialize in certain fellowships, and one of those tracks is pain management. I was heavily trained in interventional procedures, so I'm very comfortable with epidural injections, any type of injections to help with pain.
So in order to do what you're doing, you had to do a fellowship.
Yes, 1 year additional training.
That's 1 year of additional training.
Mhm.
And that's an action-packed year, that
Yes.
fellowship year.
Absolutely.
You're
Very busy.
very, very busy during a fellowship. That's right, because you have to learn a lot of things.
Yes.
And we know that you see patients in our community,
Yes.
and you also see patients in Geneva,
Yes, Geneva, Concord, and Mentor.
Concord, and Mentor.
Yes.
Okay, so you really know the Eastern I-90 corridor.
Yes.
Okay, all right, very good. And what kinds of things do you learn in a pain management fellowship?
All aspects of pain. We primarily see a lot of low back pain, neck pain, but I also deal with joint pain, knee pain, hip pain.
Oh, is that right?
Yes. Mhm.
Oh, okay, I did not realize that.
Yes. Mhm.
Low back pain and neck pain being so common.
Absolutely.
They're very, very common problems.
Absolutely. Low back pain being the #1 problem I probably see in my practice.
I see.
We had a chance to talk before we went on the air, Doc, and Brenda said that, as she just mentioned, that lower back pain is very, very, very common, and I suffer from that. Maddie suffers from it. Have you ever heard of a shot called the Bonnell shot?
No.
It's a shot that it almost seems like it's a steroid that they shoot in your back for once every, I think you can only have it once every 4 months, and it's supposed to relieve the pain.
Okay.
And I don't know whether that is something that a lot of people get, or I've heard about it, but I don't know that much about it.
Well, I do specialize in epidural injections, which is essentially the same thing, injecting a little bit of steroid, a little bit of numbing medicine at the site of what's causing your pain.
Really?
Yes, and patients can get on average anywhere between 6 to 8 weeks of pain relief. It's not permanent. I can't fix what's going on, but I can
Right.
help relieve the symptoms.
What would you do for Matt and I that with this lower back pain? I think it's sciatica that I have, but I would come to you and you would give me procedures to do, or
Right. I would, evaluate you, assess you in the office, do a thorough physical exam.
Yeah, it's important to before she intervenes, obviously, she's got to define what the problem is, so
Right.
she
Sure.
can tailor the intervention correctly.
Absolutely.
So there's quite a bit of preparation gathering of evidence and so on.
Absolutely. I would like to see an MRI just to get, a closer look at what exactly is going on. But I typically, tailor my treatments to a multimodal approach or a multidisciplinary approach, which basically means getting patients into a good physical therapy and exercise routine. I can prescribe medications that can help with nerve-related pain. And if you are a candidate for an injection to get you out of this acute pain flare, that's something I could do as well.
And I wanted to ask you too, when are you in Conneaut? 1 day a week, 1 or 2 weeks?
2 days out of the month, every other Monday.
Okay.
The second and fourth
Good
Mondays.
to know.
Mhm.
Good to know. I'm glad you brought her in, Doc, because I had no idea she was here,
Well, that's, that's part of the sort of the mandate, if you will, that this show has, is to make sure that the public understands what is available here in our town,
Right.
so that you don't have to, you don't have to drive to Cleveland to see her.
Right.
You have to drive to this hospital to see her.
That's cool. That's great.
Big difference. Right. Now, there are situations where, obviously low back pain, the conditions that cause that, there's a spectrum of conditions that cause that.
Absolutely.
And some of them are amenable to lighter interventions, and some of them can include up to and including surgery to fix them. Now, something that I think will be helpful for the public to know. All right, here's a person and they've had back pain, okay, and now they're whoa, it got worse. Fairly abruptly, it got worse, and now it's really hurting, okay? But they also have a sensation of kind of an electric shooting pain going down their leg, okay? Now, usually that suggests that there's a peripheral nerve involved in there that's being compromised. To put that in other language, and doctor can explain this much better than I can, but there are nerves that innervate all parts of the body, particularly the leg and the lower back. The nerves that carry sensations from the lower extremities come out of the spinal column there, right? Okay, and where they come out of the spinal column, they go through a little hole, a little opening, and that can narrow.
Yes.
Okay, that can narrow for a number of reasons. Some having to do with what goes on with the vertebral body, some just has to do with the bones aging and changing and building up. But they can squeeze that nerve.
Yes.
That usually is felt to be ominous because the nerve is being compromised, the blood supply to the nerve is being compromised, the motor nerves travel with the sensory nerves, and if that nerve is permanently injured, you can lose motor function in your leg.
Yes.
Is this accurate?
Yes.
Okay, so if you come in, if a patient comes in to see you and you get the sense that there is this pain that is potentially compromising a nerve, what can that patient expect? They come to see you, they tell you this, you get wind of this, and you see that this might be going on. What happens next in a situation like that?
So I, try to explain to them and set, realistic pain goals, because obviously if there's some type of compromise, I can't fix what's going on, but I can help try and control symptoms with nerve pain medications and so forth. But if there is some loss of motor, the patient's weak, I would probably send for a surgical evaluation just to get a second opinion to see what's going on.
So those are patients who would, if they had not had an MRI previously, they certainly would get one now.
Absolutely.
Pretty accurate study.
Yes.
Really shows you the anatomy pretty well. Okay, and does not have the radiation burden that a CT scan has.
Right.
So is it right for the public to have the idea in their mind that an MRI is safer for them than a CT scan is?
I would say so. As long as there's no contraindications for them to get an MRI.
Right.
Pacemaker, for example. Or,
Right, it can't have any metal in it.
Right, exactly.
Right, but the pictures that come out of an MRI are amazing. I mean,
Yes,
they're-
absolutely. And I think a lot of the times the patients come in, they'll have an X-ray, and they think that can show the entire picture. But I like to explain that X-rays are good for looking at bone, whereas MRI can really show us the discs, the nerves. It can really show us a lot more information in terms of what's going on.
Exactly. And folks, when you're talking about your spine and you're talking about the nerves that come out of the spine, what you want is accurate information.
Yes.
You want Dr. Beck to really be able to see exactly what's going on with you.
Absolutely.
And that's where the MRI comes in.
Yes.
Brenda, what are your thoughts about, I'm just calling you doctor, I'm sorry.
That's okay.
What are your thoughts about a chiropractor or a masseuse in a situation like Dr. Bryant's talking about?
I mean, it could offer some additional benefit, but I mean, if there is, significant compromise or tightening of the area, obviously when there's movement, there's probably some swelling, could irritate the nerve, can get that sharp shooting, shocking pain down the leg. A lot of people, refer to that as sciatica, for example.
Right.
I mean, I think any type of physical therapy exercise routine is very helpful because the muscles around the bones of the back can act like a splint for the spine and can, hopefully relieve some pressure off the disc, relieve pressure off the nerves. Again, but if that's not helpful, then I would probably, refer to a surgeon, get a surgical opinion. But again, a lot of surgeons, they won't operate unless the patient has exhausted all conservative measures, which chiropractic therapy, massage therapy can be a conservative measure.
Right. I think, Doc, you were aware that my mom, who's going to be, she's 91, I think now, but a couple of years ago she had the stenosis, and she had to have the surgery.
Right.
But you know what? In 2 days she was walking around. I mean, she couldn't walk before that, so
Right.
she needed that surgery.
Right.
surgery.
Very, very common, especially in our elderly population. At least by the time we're 65 or so, and as we age and live our lives, this degenerative process will happen. And the way that I explain it to my patients is, our bones sit one on top of the other with a cushion in between, which are our discs. And so when we're young, the discs are nice and hydrated, but as we age and live our lives, the discs become dehydrated, so the bones start coming together. Well, the body naturally wants to compensate for those bones coming together. So what happens is bones get laid down, you get arthritis, the joints of the back get bigger. There's also these ligaments or supportive structures within the spine that get bigger as well to try and help with stability. Obviously, there's a lot of real estate in the spine. But unfortunately, what can happen when all those things get bigger, it can get very tight. So patients will often complain of back pain and or leg pain with walking. They can't walk a long distance. If they sit, they feel a lot better.
Right.
Leaning forward when they go shopping, we call that the shopping cart sign. They'll lean forward and they can walk in the shopping, and shop for a long period of time because it opens up that space and it doesn't allow for it to be as tight. But very, very common in our elderly population. Typically, it can be hard to treat conservatively, what I can offer in terms of conservative treatment. And so sometimes, you refer to a surgeon, and if they recommend surgery, patients can get a lot of benefit.
I think people are getting a sense of the continuum of care with these problems. Surgeons are pretty much universally of the opinion that all conservative measures should be exhausted first, and surgery is a last resort.
Right.
However, as Pat just told us, and we're all aware of many, many cases where that last resort turned out to be crucial. I mean, crucial in terms of the patient's quality of life and ability to function and so on. So while we respect surgery, and particularly, spinal surgery, we respect that as a major intervention. We also, we're not afraid of it in the right circumstances because of the tremendous benefits that it can offer.
Yes.
All right, now, what is an epidural injection for back pain? What is that?
So I explain it with regards to when women are pregnant and they get epidurals. The difference is when a woman is laboring, obviously it's a continuous, meaning the medication is infused over a long period of time. It's the same concept. What I do is I use the x-ray machine to know exactly where I'm going. I
okay.
typically have patients lay on their stomach so I can have access to their back. Once I figure out where my target location is, I use some numbing medicine. I use a needle, I use the x-ray machine.
So you numb the skin?
Yes, absolutely. Numb
Okay.
the skin. Use the x-ray machine so that I'm very precise. I know exactly
So
where
that's
I'm
kind of
going.
like real time?
Yes.
Fluoroscopy,
Yes,
basically?
mhm.
Okay, and so you can watch the needle go where it's supposed to go?
Exactly.
So
I
it's
can
very
watch it.
controlled.
Yes, yes, absolutely. Right to the target area. I inject a little bit of dye to make sure my medication is going to spread exactly where I want it to go, and then I'll inject my medication.
And then you inject the medication. And what is it? What is the medication?
So it's a mixture of numbing medicine and steroid.
Okay. Now, steroids are one of these things that have a kind of a fearsome reputation because of their side effect profile, but at the same time, they're absolutely life-saving in certain circumstances, and there are plenty of times when they're the only thing that really works. And so you're not putting a whole ton of steroid in there.
No, no.
A small amount.
Right. a
So
small
people
amount.
shouldn't be afraid of getting a steroid.
Right, right. And I tell a lot of patients, instead of taking the steroid by mouth where it goes everywhere, I'm actually concentrating and target to the area in need.
Are there side effects with these shots?
When you, well, for long-term steroid use, yes, so there is a limit in terms of how many you can get within a year.
Yeah.
So you can only get 6 within a year.
Okay.
But immediately, some patients might feel a little flushed, they might have some problems sleeping that night. But long-term use is what we're worried about.
Matt and I have a friend that we do another show with, and she said that she took the shot, but she had apparently side effects from it and never got another one again, but that was just her. She said
Oh, I
that
see.
might be fine for somebody else.
Right,
So.
Usually and correct me please, but the number of people who experience a significant side effect or reaction or problem with an epidural injection of this nature, that is an extremely small number.
Right, very
Really?
rare.
Very,
rare.
very small.
Okay.
Almost never happens.
Okay.
So in terms of the person that you just mentioned, from my point of view, I would really have to dig into that case.
Mm-hmm.
I
And
agree.
find out exactly what happened, exactly what the reaction was, and so on, because you can't really make any kind of a conclusion about it. Don't have
Right.
enough information.
Right. Yeah.
What we do know is that the overwhelming majority of patients do not experience any
Right.
adverse effect with the
It's-
injection.
Right. It's kind of like when you hear someone went to the dentist and they got a Novocaine shot and then their heart started racing and they had a reaction to the Novocaine, but it's something completely different because it's very rare to get a reaction like that.
Right,
And
right.
so, but just like Dr. Bryant said, we probably have to dig in, kind of see exactly what happened and so
Okay.
forth.
Good.
All right, so could you give us a kind of a sense of the typical presentation of a patient who is going to benefit from an injection?
Sure. A patient who has back and or leg pain going down the leg, it could be sharp, shocking, shooting, burning, numb, tingling, I think could definitely benefit from an injection. Also, I do other procedures for just primarily back pain. I could do what's called a diagnostic test, which just means I want to put a little bit of numbing medicine right next to the nerves that can supply the joints of the back. And then I use that information to see if the patient would be a candidate for the second step of the procedure, which is called radiofrequency ablation. It's a fancy way of saying burning the outer layer of the nerve. The nerves that supply the joints are very small, like a piece of hair. So you can put a needle right next to it, burn the outer layer, and then allow the patients to get, on average, 9 months worth of pain relief. So the caveat behind that is the outer layer of the nerve will grow back. Some patients can get 3 months worth of pain relief. Other patients maybe 18 months of pain relief. Everyone's different in that sense. But on average, when they did the research studies, it was about 9 months worth of pain relief.
Well, in order to really appreciate what this means, you have to actually talk to a patient who is experiencing that kind of pain.
Right.
You ask them what it's worth to them to be rid of that pain for a week. All right, let alone 3 months, let alone 9 months.
Right.
What is it worth to be rid of this terrible? Because this is no joke. I mean, people who are going to go down this road and who are going to require this kind of information, it's not because they got light pain. I mean, this is life-controlling pain.
Right.
It just screws up your life. You can't, you know. So, if you can offer some relief and some freedom from that, that's
Right. I
very,
mean,
very significant.
I did the procedure for a gentleman back in October. I saw him again in May. You could also do it for the knee. I did it for a gentleman in September, and I haven't heard back from him, so I'm assuming no news is good news.
It usually is in that
Right.
situation. If the pain comes back, you generally hear about it.
So, I mean, it could be very beneficial. And for the knee, you know, patients who probably or possibly aren't candidates for a knee replacement or who don't want to go and have a knee replacement, it could be very beneficial for pain relief.
That's fantastic. Well, you know what we're talking about here, the local anesthetic that doctor gives immediately numbs the nerve, and so you get some relief instantly. But the steroid is an anti-inflammatory. It's probably the most powerful anti-inflammatory that we know, and what that means is there's this phenomenon that happens with people. It's called the inflammatory response. Okay, anyone who has ever stubbed their toe knows what this is, or hit their thumb with a hammer knows what this is.
Yes.
The tissue gets injured, and then a whole lot of fancy biochemistry happens, but it's fairly clearly defined in the sequence and what things happen. But a whole lot of stuff happens, and when you look at it in the aggregate of what happens as a result of all those reactions, it's called the inflammatory response. Tenderness, swelling, heat, that kind of thing. And that is what's going on in the areas that you're dealing with.
Yes.
It's inflamed. And that's why a powerful anti-inflammatory can be beneficial.
Yes.
Right.
Matt, you had a question earlier that you wanted to ask about the opioid situation.
Yeah, it's common, it was common for doctors to prescribe oxycodones
Yes.
and that type of medicine for
Yes.
pain. Is that the gateway to the heavier?
It's such a controversial subject. So back in the late 80s, early 90s, we thought pain was the fifth vital sign. A lot of physicians were prescribing heavy opioids for pain. A lot of the pharmaceutical companies were actually advertising and saying that these medications weren't addictive, which isn't true. And so we had this huge crisis. The number of medications that were prescribed, the number of accidental overdose deaths just tripled. And so now the pendulum has swung the other way, and we're really getting away from these, potentially harmful and dangerous medications. There hasn't been any good research studies to support that long-term opioid use is helpful in pain. It can actually cause an opposite reaction where you're more sensitive to the effects of pain. So I'm very conservative with that regards. I'm very what's called evidence-based driven. I'm a new graduate, and so a lot of what I do when in my practicing clinic is based off of research studies and what can actually benefit the patient in the long run.
Which is obviously what you want.
Right, exactly. So why give a medication if we know in the long run can actually be more harmful than good?
Well, I think of what Matthew's getting at here. There's one of the huge factors, obstacles, I don't know if you will, is the requirement for a real fundamental change in public perception and public understanding. It's a very natural thing to say, I'm in pain, I'm going to the doctor's going to give me a pill that's going to make my pain better.
Right.
That's a very common thing, all right? And that's an expectation that people have. And one of the imperatives, I think, that's really been going through healthcare for the last few years and is going to continue, is that people understand better what is going on with them, understand what is necessary for them to maintain their health, and to really kind of take some responsibility here.
Mm-hmm.
To take some responsibility to understand and make rational decisions.
Mm-hmm.
And what doctors will do, it's not just an arbitrary thing, well, we're going to do this. Doctors will explain, and the public can come to understand that the doctor is doing what they're doing based on the evidence.
Mm-hmm.
And this business of being based on the evidence is obviously, that's rational, that's the scientific method. But more and more, that's what's being emphasized.
Right.
And if the evidence is that this medication is going to hurt you long term, that's important information for you to have. I mean, why would you do that?
Doc, didn't a few years ago, didn't something go into effect where physicians were being watched as far as giving out these kind of?
Well, that's only gotten more and more intrusive. It's
Right.
gotten
Really?
more and more. Oh gosh,
Right,
yes.
right.
Watched very carefully.
Yes.
Right.
I actually went to a meeting and the district attorney said, if you don't think we're watching, we're watching.
Is that right?
Yes.
Sure they're watching.
Oh, absolutely.
You know, I had 4 teeth pulled here, I don't know, a couple years ago. And so I asked the dentist, I go, can I get something for pain? He goes, yeah, ibuprofen. That was it.
Yeah.
Yeah. Well, see, now, in my view, I really want to hear from you
Sure.
on this, but in my view, see, I would not consider that appropriate. Okay?
As far as what now?
That's going too far the other way, all right?
Mm-hmm.
We've just talked about Percocet, oxycodone, that
Right.
kind of thing, and that's one of the most abusable drugs, and it has a real high value out on the street, and it's addictive, et cetera, et cetera, et cetera. Okay, I prescribe a lot of it. I prescribe a lot of it. When I make an incision on somebody, I have just subjected them to some serious pain.
Mm-hmm.
Okay? And there is a role for those medications in the short term. And when I prescribe them, it is in the short term. Because I know that the day after they have their operation, it's going to hurt like a son of a gun. Okay? And that's just a fact. And I don't want my patients to have that kind of pain.
Right.
All right? So I give them. And I know the natural course of these things is that over the next few days, that pain is going to dwindle. It's not going to disappear, but it's going to dwindle down. And then after a couple, 3 weeks or so, it's really nothing there.
Right.
So they're not going to be on these medications long term.
Right.
My point being that there is definitely a role
Right.
for those medications, and where they perform a huge service
Right.
to the public.
Right. And that's what they're designed for acute pain.
Exactly.
When you have planned tissue trauma, you're having a surgery, absolutely you're going to be in pain. And these are what these medications are for. The problem is if when someone's on it for 20 years is when you start getting into problems.
Right.
But absolutely, a couple weeks, because you've had surgery, oh, absolutely, you're going to be in pain.
So that's my comment about the dentist.
Gotcha.
Okay?
Yeah.
See, he subjected you to planned tissue trauma,
Right.
pulled some teeth out.
Mm-hmm.
You're going
Well,
to be in pain.
you're going to have pain from that. That's a role from these. And being afraid that some bureaucrat from a regulatory agency is going to slap you on the wrist. Well, what's more important to you, taking care of your patient or that?
Exactly.
Especially since you're not going to get in any trouble for doing things that are appropriate.
Right. Right.
The doctors who I hate to say this, the doctor knows this, the doctors who get in trouble with this, they'll just write big numbers of this stuff. They won't even see the patient. It's almost like a mill. And man, those guys are getting busted.
Sure.
Believe me. I see it, you see it, we see it.
Yes.
The stories, this guy just got, nailed. But the stuff that they're doing is wildly
Right.
inappropriate.
Right.
Okay, it's not like, so if somebody comes to see Dr. Beck and they have back pain, it's a completely unrealistic expectation that she is going to put you on Percocet for the next 5 years.
Right, absolutely.
That would be an unethical thing to do based on the evidence. Is that right?
Yes, I agree.
It's not that, she wants to find She wants to find modalities, ways of solving your pain problem, or at least getting it to a much more manageable level that don't put you at risk. That's what this is about.
Right. And my colleague, Dr. Searles, and I, we were wanting to start a functional restoration program. The Cleveland Clinic has one downtown that's been very successful, but it basically approaches pain, chronic pain, with two different modalities or two different pathways, because pain is not only a physical experience, but it's an emotional one as well.
That's right.
And so we want to try and tackle that at both aspects, and we're very hopeful to start this program very soon to help patients. I think it'd be very beneficial for
We would be extremely interested in that. We have had Anna on this show.
Okay.
You know, and she was very impressive. Okay,
She's great.
obviously a very smart lady.
Yes, Harvard trained.
You know, and I did not realize that you were working with her to
Yes.
put together
What's called a functional restoration program.
folks, that's going to be a powerhouse. You got these two ladies running this thing. It's going to be, when that gets up and you're ready to launch that, please let us know. I would
Sure.
like to have you both on this
Okay.
show.
Yeah, that'd be great.
Yeah, okay, that would be.
Yeah.
She's great.
Oh boy, that's very exciting.
Very
That's very
excited.
exciting. So, folks, there is an opioid epidemic. I just want to pick up on what Matthew has said. There is an opioid epidemic. If you look at the statistics, the deaths by overdose have skyrocketed, and they're continuing to skyrocket. And it's not just because heroin. It's not just because the border is porous. We're talking about pharmaceuticals. Okay. And so it is a huge problem. It has become a huge problem. We still want to prescribe those medications, but in the right setting and for the right duration. And it's important for you, the public, to understand that this is a big problem, that we all have to take it on together. And that doctor here offers a myriad of different things to solve the pain problem without exposing you to that kind of risk.
Right.
What are your hours, Doc, in Conneaut?
So Conneaut, I do a half day. I'll see patients in the morning for clinic, and then I do procedures in the afternoon.
Obviously, appointment.
Yes.
Okay. Okay. Excellent.
Yeah, and Matthew's going to make sure that your phone number is displayed during this program. People
Okay.
can see it.
Sure.
And folks, I think it's important for you to understand you do not necessarily need a referral from your primary care doctor to come and see Dr. Beck. Obviously, if you're going to see your primary care doctor, and you have pain in your back, pain radiating down your legs, pain in joints, chronic pain sorts of problems, it is perfectly acceptable and the right thing for you to do, folks, to tell your doctor, I'm having these pain issues, can I go to pain management? And they will send you over. But if you are having pain, you haven't seen your doctor, you don't have an appointment coming up, what have you, you can call the number that's being displayed here and make your appointment to see Dr. Beck that way. I just want to say one other thing. I really want to embarrass Dr. Beck. I'm going to try my best. Okay, one of the things that we kind of keep track of, not just us, but across the UH system, and more health systems are doing this, we are looking at what are called patient satisfaction scores. And that's where the patients, the patients who come in to see UH doctors at our hospital can rate various aspects of your experience. And we look at those things and we take it very seriously, and we're constantly putting together initiatives to improve those. Dr. Beck's patient satisfaction scores are always 100%.
Wow.
That's amazing, okay? Consistently, I've been, because I'm chief of staff, I watch
Sure.
these things.
Sure.
And her patient satisfaction scores are very, very high.
Thank you.
So,
Well, thanks to my patients.
yeah. So that's just another little word for you to know about coming to see this lady. All right, well, Doctor, we are very, very pleased that you come out to our town
Thank you.
and that you provide service to our public, to our patients. And we really appreciate you taking the time to come on this program.
Sure.
Would like you to kind of think about this experience here And think about, gosh, maybe if you came back and talked a second time about very specific things
Okay.
to help to educate the public, we would love to have you come back.
Sure.
And when you and Dr. Searles get this thing ready,
Yes.
ready to have it presented, please let me know so
Okay.
that we can get you out here
Sure.
to do that.
Sure, absolutely. All right, thank
Excellent,
you.
excellent. Glad you came in.
Thank you so much.
All right, folks, as you all know, your health matters, and we'll be seeing you next time around. Bye-bye.